Well, good afternoon, everybody, and welcome to all of you who've joined us for this online media briefing. I'm Lyndall Byford from the Australian Science Media Centre. The Doherty Institute has presented its final modelling to National Cabinet on Friday. And this modelling looks specifically at key populations and risk settings, including First Nations people, culturally and linguistically diverse populations, and schools. And they've also reviewed the public health response measures that are needed for phase 3 and beyond, as well as the impact on changing border arrangements. So today's briefing is really to bring you the people behind that modelling so that you can have all of your questions answered. Joining us, we have 5 speakers. First, we will hear from Professor Jodie McVernon, Director of Doherty Epidemiology from the Doherty Institute. Jodie is going to give an overview of the modelling. And then we'll also hear a short summary of the contribution from the other speakers. So we'll have Dr. Rebecca Chisholm, an applied mathematician and lecturer at La Trobe University, Associate Professor Nick Geard, School of Computing and Information Systems at the University of Melbourne, Dr. Freya Shearer, Senior Research Fellow at the University of Melbourne, and Dr. Nick Scott, Head of Modelling and Biostatistics at the Burnet Institute. Of course, we're here to ask questions, so you can type your question in at any time into the Q&A box, or you can raise your hand and we'll unmute you once they've finished speaking and you can ask your question directly. If you're joining us by phone and you have a question, you can raise your hand by pressing *9 on your dial pad and we can unmute you that way as well. So we will begin now, handing over to you, Jodie.
Thanks very much, Lyndall, for your help with all of this, and thank you all for coming today. Obviously, it's been a big few months in order to deliver on this second tranche of work, and I do apologise that such a weighty mass of reports was only released this morning in advance of a press conference this afternoon. So we do anticipate there might be more questions and other things coming up over the next few days. But briefly, obviously our first tranche of work that delivered to National Cabinet at the end of July defined overall threshold targets for vaccine coverage that would help Australia transition through its national plan phases. And at that time, there were sort of several key messages we made. The first was that vaccines alone would not be enough, that Australia would need to have ongoing public health responses and some degree of social constraints in place to help support vaccination and to keep COVID case numbers low. And that was seen as the most beneficial phase for our next recovery, for stability and economic recovery, and that was through a combined analysis with Treasury. We also anticipated in that there would be heterogeneity of vaccine coverage and also vaccine impacts, and it would be very important to understand that and to think about risk populations and risk settings where additional supports might be required. And this work really picks up on those elements and has been highly consultative, working with various government departments, key advisory groups and other stakeholders, and so has been really well informed by pragmatic considerations and implementation considerations, and we've all learned a lot through the process. So essentially it's 5 times the work of what we delivered before. As ever, it's very many people, and I'm delighted that my co-panellists today represent some of the other institutions involved in what we call Doherty modelling, but is in fact a national consortium involving a very large number of people. And I'll be letting them pick up on specific elements of the work. We don't have someone for every report here, but we're very happy to answer questions on any aspects of the work that we can help you to provide some insight into. Thank you very much.
Thanks, Jodie. Rebecca, did you want to give a quick summary of your contribution?
Sure, thanks, Lyndall. So I was involved in the part of the work package which was looking at reducing the risks associated with outbreaks in remote Aboriginal and Torres Strait Islander communities, and particularly looking at questions around what are the coverage targets which might be appropriate in this setting. So when I say coverage, I mean vaccination coverage. Looking at whether there's a role for including in an outbreak response a reactive vaccination program, and then looking at whether there are other useful additional public health measures that might be useful to regain control of an outbreak in this setting. And so what we did was we used our model to simulate outbreaks in a remote community of varying vaccination coverage levels prior to the outbreak, and also under different response policies, which were really informed by current guidelines around response in remote communities. And what we found was that high coverage of vaccination prior to an outbreak is really crucial in being able to reduce the impacts of a COVID-19 outbreak, both in terms of impact on transmission, but also health impacts. We found that of the strategies that are currently recommended to respond to outbreaks in remote communities, those which include removing both cases, but also contacts of cases in a culturally safe way from communities to a safe location, was associated with much improved outcomes, so improved reductions in transmission and also health impacts. When we looked at reactive vaccination, we found that this was is also another way to reduce the impacts of an outbreak, particularly in communities which are larger and with lower initial vaccination coverage levels. And we also found that being able to access effective treatments is also going to be really important in responding to outbreaks in remote communities. I might stop there.
Thank you, Rebecca. We'll head over to Associate Professor Nick Geard. Nick.
Great, thank you very much. Okay, so I was involved in the work package on looking at quarantine pathways, and we were interested in looking at how we could modify the arrival caps and quarantine pathways and what impact this might have on transmission risk. And so we updated some of the previous work we'd done in this area by recalibrating to some of the higher transmissibility around the Delta strain, and also to take into consideration the fact that many travellers and much of our population are now vaccinated. We simulated a quarantine system. So we simulated arriving travellers moving through that system, staying either within a hotel or a home quarantine environment for 7 or 14 days and various other parameters. And we simulated potential transmission within that environment. We simulated testing in that environment. And we used all of this to estimate the rate at which quarantine breaches could be anticipated to occur under these different quarantine pathways. As a second phase of this work, we then looked at the impact of those potential breaches. So we simulated transmission within the community and the effect that infections entering the community from the quarantine system would have on transmission. We simulated that both in an environment where there was ongoing transmission of COVID, and also in an environment where there was sort of COVID zero, no ongoing transmission. The key findings of this particular work package were, perhaps unsurprisingly, that vaccinated travellers were much less likely to enter the community while infectious, and that actually sort of compensated for or mitigated against reducing the duration of time that they spent in quarantine. Even under the best settings, the testing remained critical for detecting travellers who arrived while infectious. And also that the environment that people were entering played a huge role in the risks associated with quarantine breaches, and that with high vaccine coverage and ongoing public health and safety measures, the infections that arose from quarantine breaches tended not to lead to large outbreaks. The main caveat, I guess, around all of the findings associated with this is we were assuming that the strain that these travellers were entering with was equivalent to a Delta strain, and that the situation might change if there was another strain introduced, which was different from Delta in terms of its transmissibility or in terms of the ability of the vaccine to prevent infection or transmission. Thanks.
Thanks very much, Nick. Freya, did you want to follow Nick with a quick summary of your area?
Thanks, Lyndall. So I was part of a work package that aimed to inform the review and refinement of public health response measures, focusing on sustainability as we transition into a phase of established community transmission with increasing caseloads and high vaccination coverage. We consulted with public health experts involved in the test, trace, isolate, quarantine or TTIQ responses in the states and territories to help develop a list of the most important questions to answer to help establish these alternate strategies. The questions mostly focused on testing and quarantine strategies for primary close contacts of cases, that is, and options for differential management of vaccinated individuals presenting as either an index case or as contacts. So we used modelling approaches to assess the potential impact on transmission of each of these strategies. First, we found that COVID-19 vaccination coverage, when it's greater than 70% of that 16 plus, around half of all infections will be in vaccinated people. And so we expect the disease to be milder in these individuals, which has implications for how likely they are to be detected by the public health system, but they will also be less infectious. So we found that while TTIQ remains critical for control, management of vaccinated cases and contacts can be simplified. For example, we found a marginal impact on system performance when shortening isolation requirements for vaccinated cases from 14 to 7 days. And finally, we found that ongoing evaluation of the impacts of TTIQ on the potential for virus spread would be needed for ongoing situational assessment. Thanks.
Thanks very much, Freya. And last but not least, Dr. Nick Scott.
Hello. So I was a part of the schools component of this body of work, and really the focus was on the use of rapid antigen testing in the school context. And this was to both reduce infections, so that's infections, not diagnoses, as well as reducing the number of days of face-to-face teaching that were lost as a result of quarantine and isolation of cases. The modelling we did was based around starting scenarios that had a single incursion into a single school. So we just start with a single infection in the school, and then we followed the outcomes of that for a 45-day period, just tracking the number of infections and number of days lost as a result. We considered primary schools and secondary schools separately because of the differences in contact patterns as well as vaccine eligibility and coverage. I suppose the first thing that we found was that when a case is introduced into a school, there's a wide range of outcomes that are possible. So without any intervention, we saw that about 50% of the time, it's different for primary and secondary schools, we could expect to see either no further transmissions or less than 5 infections in total. But then we get the other 50% of the time where we do get some level of outbreak, and these can be of varying sizes. When we overlaid surveillance, so twice weekly student testing with rapid antigen tests on top of this, we saw that it had a significant impact in reducing both the probability that there was an outbreak as well as the number of downstream infections that we observed. This is because by having the surveillance testing in place, it was detecting the index cases or the initial cases earlier so that they could be removed from the school faster. The next component was about looking at quarantine and contact tracing strategies within the school. And so in particular, we compared a 7-day quarantine of classroom contacts to a strategy called a test to stay strategy, where we have for 7 days, if there's a case in a school, their classroom contacts need to have a daily rapid antigen test before attending school, and they can continue attending school provided they keep testing negative. What we found was that the 7-day quarantine and the 7-day test to stay were approximately equivalent in terms of infection outcomes and outbreak risk. But the 7-day test to stay strategy had the considerable additional benefit that there were much less days of face-to-face teaching lost. I think that the two, so we ran a lot of sensitivity analyses, but probably two of the most important ones are in terms of the surveillance. We looked at how this would scale with increased number of incursions. And so we saw that as the number of incursions increases, then the relative benefits of surveillance testing increased, indicating that in areas that have higher risk of incursion, this is going to be a much more beneficial strategy, although it does always have benefits. And then with the test to stay strategy and the quarantine strategies, we looked at what would happen with lower compliance because it's reliant on people conducting the test before attending schools. And what we saw is that it wasn't overly sensitive to that. So with lower compliance, it was slightly less effective, but there wasn't a huge drop off or a threshold for that. So I'll stop there. Thank you.
Thanks very much, Nick. So we've already got quite a few questions coming in. Can I just remind everybody that if you are typing your questions in, can you please remember to include the outlet that you're working from? So we'll start off with Georgia from the ABC. Nick, this is probably one for you. She says the modelling shows that under a test to stay model, there could be 6 less infections for high school students compared to if close school contacts quarantine, figure 2.3.2. Could you explain why there could be less if students were subject to quarantine arrangements?
Sure. So there were, in the report, there are 4 different strategies presented in that figure. So one of them is the quarantine strategy, and then there's a second one which is quarantine with daily testing. And we're not suggesting that this is a strategy that will be adopted, but this is a more a fairer comparable strategy, because the difference is if you quarantine and you do a test on day 0 and day 6, there's still a risk of under ascertainment because of the imperfect sensitivity of that test. And so the direct comparison between the scenarios would be the 7-day quarantine and testing compared to the daily testing.
Thank you. So the next question, which is also from Georgia, is the report says the Delta strain makes hospitalizations twice as likely compared to Alpha, but that the likelihood of hospitalization is still rare. According to your modelling, what percentage of children who are infected will end up being hospitalised?
So I'm happy to speak to that one, Lyndall, and I think there's just been a little bit of a clarification needed there. So we do talk about the change in our clinical severity assumptions from the previous tranche to this tranche of modelling, and it's actually on page 23 of the synthesis report where we just try and step through the logic. So we've reviewed all of the available evidence. At the time we did the very first set of work, it seemed that there were various reports that Delta was the same or a bit more or a bit less severe than the Alpha variant. And at that time, it was clear that Alpha was more severe than the original Wuhan strains. And at that time, there was an odds ratio that we used of 1.42 between Alpha and Wuhan. And based on a review of all of the available evidence and in discussions with health, this time we chose to use a reported odds ratio of 2.08 for the Delta strain compared to Wuhan, not compared to Alpha. So it's an odds ratio. It's actually not twice as much. One was 1.4 times, one's 2 times. And being an odds ratio, it's an odds ratio of hospitalisation given symptoms. We have different likelihood of symptoms by age, and then given symptoms, progression to hospitalisation. Overall, what that means is that in younger children in whom hospitalisation is rare, overall hospitalisations may be more increased than in older individuals where hospitalisations are already more common. So we kind of describe the logic of that on page 23, but overall, we're not anticipating a doubling of outputs compared to our previous work. Thanks.
Thanks, Jodie. We're going to go to a couple of people who've got their hand up now. So we'll start with Rachel Clune. We'll just unmute you, Rachel, and you can go ahead and ask your question. Go ahead.
Thanks so much. It's Rachel Clune from the Sydney Morning Herald and The Age here. A couple of questions, if I could. Firstly, maybe a simple one. Will there be further modelling given the state of our vaccine rollout? We're pretty highly vaccinated. With the work on Indigenous communities and the LGAs in smaller areas, when was that completed and when did National Cabinet see that modelling? Because it shows a very different way of treating outbreaks in those areas. I think I'll leave it there for the minute.
So I'm happy to talk to that as someone who's communicated throughout. So I think it's really important to clarify, particularly for the work in Indigenous communities, that this was all undertaken consultatively with the Aboriginal and Torres Strait Islander Advisory Group that has led Australia's Indigenous response from the beginning. And in recent times, obviously since the advent of vaccination, that group has been looking at revising the outbreak response guidelines for remote community settings. So last year we undertook work with the Doherty Institute that helped to inform the first iteration of those guidelines. And this work has been conducted consultatively with them. And, you know, if you read through the sort of full report, it outlines that there are specific case studies and things that we've been asked to address that are relevant to the guidelines and responses. And over the last couple of months, as work has been rolling out, you know, I've attended National Cabinet quite frequently to provide updates on the work, and that's been concurrent with the work with the advisory group. So the full work was presented on Friday. All of the reports came out today, but it's been all of our work is highly participatory and consultative, and so we try to make sure that as we do the work that we refine and update and address the questions that are of most relevance to the people who need to use it to support policy.
And will there be further modelling? Is it going to be a continuous ongoing process as the pandemic progresses, or is this pretty much it for now?
So our work was commissioned by National Cabinet to support the transition phase, and this particular piece of work is finished. It's been done. Our group, obviously, various members have worked commissioned by Health over the past 2 years to undertake a whole range of projects, and should additional work be required, then we're available to be consulted on that work. But these specific projects are essentially defined as is. Obviously, we're having worked with the Aboriginal and Torres Strait Islander Advisory Group as they continue to refine their guidelines. We're very keen to be able to support that as ever we can.
Thanks, Jodie. Thanks, Rachel. We'll head over to Casey Briggs now. So, Casey, you should be unmuted. Go ahead.
Thanks for doing this again in the round of modelling. Kind of a two-part question on the schools scenarios that were simulated. First of all, did it surprise you to learn and see that the test to stay approach was, just about as effective at controlling outbreaks as quarantining an entire class for 2 weeks? And second to that, is there then anything specific about schools that leads you to that result? Could the sorts of results you've seen with schools be transferred to other sites like workplaces?
So I think, I suppose it was surprising as an entire outcome, but thinking about the sensitivity of the tests and thinking about the repeated testing accounting for that sort of reduced sensitivity, it makes a lot of sense because you do cut off the infectious days spent in school by catching them in the morning before the students go to school. And so there's a real logic to the way that has equivalent outcomes. In terms of extending it, it's not entirely clear. So one element of the schools is that the students, particularly the younger students, have a lower susceptibility to infection and they're less infectious to others because of their age. And so this would be one part of it where if a single day of infectiousness is missed in a school, that would have lower consequences than, say, a single day of infectiousness being missed in a workplace. But it is something that's an interesting question worth exploring.
Thanks very much. Okay, we will head over to Sarah now. Sarah, you should be unmuted. Go ahead.
Thank you very much, Sarah from Guardian Australia. Just another one for Nick, please. I just wanted to ask about the observation or the modelling that shows that without intervention, there was sort of a 50% difference for primary or secondary school settings, and in 50% of those cases, no or 5 cases would be recorded in total. Can you just explain why that would be? And also, given the discussion about vaccination rates for 5 to 11-year-olds, and forgive me because I haven't read all of the reports, I didn't have a chance before the press conference, but do you have any data or information on how the vaccination of primary school age children might affect an outbreak in a school setting, in a primary school setting?
So firstly, regards to the cases that lead to nothing. So I think it's 37% of the time in primary schools and 47% of the time in high schools. This is the result of a single incursion in that school leading to no further infections. And in part, this is just to do with some of the dynamics of COVID that we've gotten used to, I suppose, modelling it, where kids aren't as infectious as adults. But also there's an element of randomness to transmission of COVID, where you can have some people that have higher viral loads than others. Sometimes you get these outbreaks, sometimes you get nothing happening. So these sorts of results are, I suppose, consistent with what we've seen in the broader population, particularly from incursions through hotel quarantine, where sometimes we've seen cases lead to nothing and cases lead to small outbreaks. Secondly, in terms of the question about vaccinating 5 to 11-year-olds, that wasn't in our main scenario, but there is a sensitivity analysis in one of the in the appendix of the school's report that shows the same scenarios, but if primary school students were vaccinated as well. And so what we see is that we see a similar thing to the vaccination of secondary school students, which is that it can reduce the risk of outbreaks occurring and reduce the size of an outbreak if it does occur.
Thank you.
Thanks very much. We're going to head to a couple more online questions now. We've got a question from Laura Exton from ABC in Coffs Harbour. She's asking, is there any recommendation for a specific rapid antigen test for schools to use?
I'm not as a part of this particular report. I think the consideration of which test to use would be, there'd be a number of factors: logistics, implementation, feasibility, cost. There'd be a whole range of factors. What we've done in the report is we have looked at the reduced compliance, which is equivalent to different sensitivities of different test types. But I think there's further work to go there. Jodie, I'm not sure if you have a comment to add on that.
Yeah, no, just confirming, Nick, I guess that we don't assume the tests are perfect, and even if not everybody uses them every day, they still have merit. But there are obviously implementation trials that are ongoing in several jurisdictions, and the results of evaluating those will be very important in working out what are actually the most feasible and sustainable strategies. And also, you know, I think one of the important findings in your report, Nick, is that the greatest benefit of, say, the surveillance screening strategies are seen in areas where there is higher ongoing transmission. And so part of our work is highlighting that there will be some subpopulations in small areas where we might expect to see ongoing risks of COVID being higher than in others, and really thinking about how some of these additional measures can be targeted as adjunct supports in areas where they're most needed.
Thanks very much, Jodie. This one's probably for you as well. This is from Dennis Normill from Science magazine. He's asking, does your modelling provide any guidance or cautions that might be useful for other countries? He's particularly wondering about China.
Look, you know, I think we've tried to address a range of implementation issues that have come up in our specific policy setting. Obviously, these issues of heterogeneity are going to be important in all countries, as are the needs for other, you know, ongoing measures and controls. And so I guess all nations, as they are reopening, are finding who their at-risk populations still are. You know, we've certainly seen that very starkly in places like the US, where there have been still large epidemics in the under-vaccinated populations. And so I guess really it's for all countries to try to understand what are the key demographies and risks and other issues that really do need additional supports and refocusing of supports. I think a lot of the work that Freya's team has done is to work out how we can streamline public health responses in the majority of the population, but part of that is to ensure that we have ongoing capacity and resourcing for wraparound supports in those areas where they're needed. So I think all countries will struggle with these sorts of challenges over the next little while.
Thanks, Jodie. The next question is from Natasha Robinson from The Australian. She's asking, given that under your modelling, breach importations do not materially impact on established academics or lead to large outbreaks at 80% vaccination, is there any utility at all in Western Australia keeping borders shut until it reaches 90% vaccination?
So I'll take that one. Obviously, we can't really comment on the decision-making process that is leading to those sort of policies, but I will note that while we didn't observe large outbreaks at 80% vaccine coverage, There is still a difference, and you can see this in the appendix in figure 3.3.1 of the relevant appendix. There is still a difference between 80% coverage and 90% coverage. So at 80% coverage, there is still some infection in the community as a result of quarantine breaches, and that is reduced when you get to 90% coverage. So there is, arguably a different level of tolerance for transmission in the community could lead to a different decision about the appropriateness of opening at different coverage levels. And I guess the other point, just to sort of relate back to Jodie's earlier response about heterogeneity in the community for these particular set of simulations, we just looked at an overall vaccine coverage level of 80% in the various different coverage levels in the communities that we're modelling. But we are, of course, aware that the vaccine coverage isn't uniform across the community. And so even at 80% coverage overall, there may still be locations within a particular sort of setting in which coverage is lower.
Thanks, Nick. Next question is from Tegan Taylor from the ABC. Can you talk about reactive vaccination and how that would work in remote Indigenous communities? Rebecca.
So I probably can't comment on how it would be implemented in various states and territories. I can talk about how we implemented it in the model. So essentially, at the start of an outbreak, when a case is identified, what we did was we implemented the program, which involved finding those people in the community who were not vaccinated at that time, and then vaccinating those members of the community at particular rates, so a number of vaccinations per day. And those rates that we looked at were based on advice that we got from Northern Territory Health, which were based on, I believe, teams of people going door to door and vaccinating individuals. Thanks.
Thank you very much. So the next question is again from Tegan, and probably one for Jodie. Have you or will you looked at the effect of the new booster and third dose strategy and what that will do?
So all of the work in this particular work package assumes that immunity remains constant over time and did not incorporate the effect of booster doses. So that wasn't part of this particular tranche of work that was commissioned for the national plan. But as I say, we do undertake a lot of other projects with health over time. And we are within that work considering the importance of understanding waning of immunity for longer term population protection, and also for the ongoing situational assessment modelling that we do that reports every week, that, you know, beyond all of these scenarios, there's actually where are we now and what's happening with infection spread and what does that mean for the balance of protections in our society.
Thanks very much. Question again from Claudia from the ABC. Just on the test and stay strategy, Nick, would someone be able to walk us through how that process works in schools in a bit more detail?
So that's really the next step beyond this modelling report. I think this modelling report has sort of served to look at the potential effectiveness of that as a strategy compared to different quarantine strategies, and we've found really positively towards that strategy. And so the next step is to take that forward in terms of looking at how it could be implemented, what is required to implement that. So that would be ongoing work for other departments and people that we've consulted with.
Great, thank you. A follow-up question from Laura Exton as well, from ABC. She's saying, is there a recommendation for how soon rapid antigen testing could or should begin in schools?
So I suppose that's the same sort of follow-up answer, is that now that we've got modelling to show that it can be just as effective, we need to work with others and take that forward by looking at how and when that can be implemented.
Thank you. And Natasha Robinson from the Oz has a follow-up question as well. This is back to breaches, so we'll go to the other Nick. How many cases can you expect from breaches at 90% coverage?
Sure. Okay, so I don't have exact numbers in front of me, but as an order of magnitude, just pulling off the charts that we've got in the report, whereas it is potentially rising to within the sort of tens to hundreds at the 80% coverage level, at the 90% coverage level, it's almost a horizontal line. So it's positive, but it's very, very low. It is worth bearing in mind, though, that these aren't predictions of numbers of cases that we would expect to see. These are sort of, I guess, projections under, as Jody mentioned, assumptions of ongoing, no waning immunity and a fixed vaccine coverage level, whereas we know both of these things are going to change over time. So yeah, they're not predictions of absolute numbers, but it is there is a sort of a noticeable visible difference between the plots, so we can see that it does drop markedly under 90% coverage. Jody?
Can I just add a little bit to that too? And so obviously, there are two elements to the story. So one is what's happening in the arrivals environment, where we're talking about vaccine coverage, and also what other social measures are in place in that arrivals environment. And they obviously provide really important bolstering protection, as well as the ongoing public health response. But what we show as you step through the reports, we look at a whole range of different arrivals pathways. So, the majority of the 70, 80, 90 are for a 7-day home quarantine pathway with testing on day 1 and 5, and we have family and adult arrivals. We also look at no quarantine pathways, and we look at different lengths of stay, and also look at doubling the number of arrivals. So what we see is that basically, we scale the set point of infections depending on how many people come in and exactly what pathways they come through. The main thing is, are we retaining that within the capacity to be able to manage those cases? And because of the constraints in the environment into which people arrive, is it stopping those case numbers from escalating? And so that's really, the sort of the dual story of this is arrivals coming in one end, but actually what they're coming into is really critical for that ongoing control.
Thanks, Jody. While we're on borders and control, Jim Wargo from the AFR is asking Nick specifically if there were any surprising findings in relation to quarantine and border control.
So in terms of surprising, I think a lot of the findings sort of confirmed what we might have suspected, along the lines that that vaccination was very effective. I guess if there was anything that was sort of pleasantly surprising to see, it was just that that finding is discussed that under the high vaccine coverage and public health and safety, ongoing public health and safety measures in the community, that even with the rate of arrivals or the number of arrivals increasing, that so long as they were vaccinated, as long as we had this ongoing community environment that was able to manage the occasional breaches that occurred, that there wasn't a substantial difference or there wasn't a substantial impact on the ongoing level of transmission in those communities. So I think.
Thanks, Nick. Question from Emily Burke from the ABC. Can Jody make sense of the apparent split within some of the medical community over the risks posed to children of COVID itself and the risk of adverse effects of the vaccine? Can the risks of both the virus and the vaccine be objectively weighed up?
So I'll talk of someone who looks at the evidence. So we do have very good evidence about the very small risks of severe disease outcomes in children. And obviously, as our various committees go through, they will weigh up those risks against risks of adverse events. That's not a process that we need to be involved in. Obviously, we do look at disease outcomes in our models and we calculate those and we see those as something that's, to be reduced and avoided. But that balance of risks and benefits is something that we rely on our regulators and advisory groups to do and to provide that informed advice. And obviously then different individuals will have their own personal perspectives and risk tolerances around those issues. But we are advised by the people who make the policy advices and determinations for Australia. Thank you.
Thanks, Jody. Courtney Gould from the NCA Newswire is asking, is there a recommendation that test to stay be expanded into workplaces?
So we haven't looked at modelling of that, so I can't make a comment on that directly. And there's reasons to believe that test to stay at the workplace could be different to test to stay in the schools. So we don't want to draw that conclusion until that's been explicitly done. It would be worth, so there's, I mean, the first step in what we did do is we've looked at the test to stay in the schools. There's a number of implementation and pilots and things that are going on in regards to this, and we can watch the data and see how that goes and then think further.
Thanks, Nick. And I think we've come to our final question, which is from Lauren Exton at the ABC, and this is for you, Rebecca. Could you please further define reactive vaccine approaches with regard to First Nations communities?
Sure. So, I mean, I can do it in the context of how we implemented it in the model. So I'll take that approach to answering the question. So I said before that when the program is initiated in the model, we find those who are unvaccinated. And what we do is we order those people who are unvaccinated in terms of oldest age first, and they receive, they're prioritised essentially in the model. And we essentially give the vaccine to as many people in the model that we can, given the current rate of vaccination that we set in the model, which is the number of vaccinations per day. And so we go through step through in the days in the model, and people who are unvaccinated receive their first dose. After a time in the model, they also then receive their second dose, given we have to wait a period of time depending on the type of vaccine that they receive for their first dose. So there are some delays until seeing the effects of vaccination in terms of reducing transmission and also reducing severe outcomes for those people who receive the vaccine during the simulation. And we take those time-dependent effects into account in the model. Hopefully that helps clarify.
Can I just add a little bit, maybe just based on experience? So, the real distinction here is clearly, preemptive vaccination, maximising uptake rates in all people in Australia is the most highly desirable way to prevent disease. But regrettably, we have seen occasions where outbreaks have occurred in settings with still low vaccine coverage. And so there was a genuine question as to whether implementing vaccination as part of a community-led and engaged response would actually be sufficiently timely to make a difference because of these delayed vaccine effects that Beck is talking about. So it was a genuine and specific question about whether at the time of rolling out, the usual public health responses of, finding cases and isolating them and quarantining contacts and so on, whether this would have additional benefits. And we did in fact find, in the community example that Beck's talking about, in a larger community with low starting vaccine coverage, that, clinical cases could be halved by a reactive vaccine approach. So it's really something that goes alongside, supports other outbreak response, but it's part of this way of now thinking about vaccination as an additional tool in our kit and thinking about the most effective ways to be able to use it to minimise harms. And really what we've seen this used in Wilcannia and other places. One of the sort of key assumptions in your model, Beck, was that, final vaccine refusal was only 7%. That was based on examples that we've seen in Western New South Wales in response where this has been used as an effective strategy.
Thanks very much. I think we've actually hit the end of our questions, which is great. Did any of our speakers have any sort of final wrapping up words, or was there anything anyone wanted to add before we sign off? No, I think that probably covers it then. So thank you very much to everybody who's joined us today. There's going to be a full recording of today's briefing available shortly. We'll put a copy of that on Cymax, and the Doherty will also have a copy of that recording soon. If you've got any further inquiries, you can contact us at the AusSMC on 08 7120 8666 or email us at info@smc.org.au. If you want to follow up with any of the speakers, please contact Rebecca Elliott. She's on 03 8344 8360 or rebecca.elliott with 2 L's and 2 T's at unimelb.edu.au. So thank you again for all of the speakers for answering all those questions today. It's been fabulous.